Good afternoon, everybody. A very warm welcome to Dr. Priya, who will be joining us as a speaker today on a very important topic, the ICU care bundles, which form the integral part of our critical care system. And our nursing colleagues, I extend a very warm welcome to everybody attending today's STEP session. And you all are aware that this is a very important topic, and especially where the nursing people are in direct contact, and it really is important because it is directly involved in the patient's safety. And let's begin the topic. Just wanted to introduce to our speaker today. So Dr. Priya is working in the NGM Healthcare Chennai and is as a consultant, and has multiple laurels to her name. So without wasting any time, I would like Dr. Priya, over to you.
Yeah, thank you, Dr. Juhi. So today we are dealing with a very, very important topic. So rightly said, we'll proceed with it. So we all must have experienced such a scenario in our ICU. So let's look at this patient first. A 58-year-old patient admitted with a community-acquired pneumonia. So this patient was intubated, was on noradrenaline, vasopressor support, and with the help of the ICU team, the patient showed an improvement, like with antibiotics, with the care. He had multiple lines that had been placed, a central line, arterial line, and a catheter. So he was at fifth day. So he was about to be extubated, weaned off the ventilatory and the vasopressor support. But then he develops fever spikes, drops his pressures. There is increased secretions. So what are we dealing with? So a patient who primarily gets admitted for a condition during the course of treatment develops another infection. Okay, that's a hospital-acquired infection. Okay, that's a nosocomial infection that we are dealing with in this patient. Especially when the patients have such infections, it is not only going to be increasing the morbidity, sometimes the patients even succumb to such infections. So our first aim would be, first, do no harm to the patients. So how can we prevent these infections? The COTI or the VAP or like other infections, the nosocomial infections, we can follow some good practices. So what are these good practices? And what is a ICU care bundle? So when these evidence-based practices, which are put together as a package, so these are shown to decrease the rate of infections and complications related to critical illness. So these are known as the ICU care bundles. Usually these practices are bundled as 3 to 5 elements or a little more together. When followed appropriately by the hospital staff, this is going to prevent a lot of morbidity, mortality, and even going to decrease the cost the patient is going to face. So this will benefit the patient. This will decrease the ICU stay. This is going to reduce the financial cost, and it is going to be clinically effective. So what are the different elements of the ICU care bundles? So it's a ventilator bundle, a CLAPC bundle, COTI, surgical site infection, and a sepsis resuscitation bundle. So we'll be looking at every bundle separately. So going on to the ventilator care bundle. So what is a ventilator-associated pneumonia? A pneumonia developing in a patient after 48 hours of intubation and mechanical ventilation is known as a ventilator-associated pneumonia. And this is the second most common cause of nosocomial infection, and it increased the mortality of the patient by 50, almost like 50%. So how will you diagnose this? Usually the patient on ventilator develops fever. There will be when you check the labs, there will be an elevated WBC count. You can find your frequency of suctioning will be going up. So you need to frequently suction, and you can find the secretions purulent and thick. So these are some of the findings that you can appreciate. And when you do an X-ray, in the right X-ray, you can obviously see a patch. Okay, there is white colored infiltrate. This is the normal lung. This X-ray, you can obviously see a white colored infiltrates in the lung. So probably the patient has developed a right, lower and a middle zone pneumonia. Okay, when you send these secretions for culture, you will find the gram stain turning out to be positive and the culture after 3 or 4 days detecting the organism. And the oxygenation, the ventilator settings will go up. The FiO2 requirement will go up. The PEEP requirement might go up. So this is when you'll have to think that you're dealing with a ventilator associated pneumonia. So how can you prevent this? So we have the ventilator care bundle. So the first and foremost step in every bundle is the hand hygiene. So that forms the most important component. So head and elevation to 30 to 45 degrees. This is another important component. So when you enter an ICU, you always have to find the head end of the patient bed needs to be propped up by 30 to 45 degrees. If not, you have to question why it is not being done. So if it is not done, probably it should be a contraindication in some patients who have a spinal injury or a fracture to the spine or some other indication, which is making us keep the patient in supine position. Otherwise, always it's mandatory that every patient has a head end of the bed elevated by 30 to 45 degrees. Interrupt the sedation. So what is that? So whenever your patient is on a minimal dose of sedation, you stop the sedation. Okay, 6 o'clock or some specified timing, you stop the sedation unless and until the patient is really restless or not, you need to provide some. You maintain a RAS of 0 to 1. So you keep the patient calm and then you try to awaken the patient. So see whether your patient is responding, is trying to obey your commands. So in that scenario, you will be trying to by doing the sedation interruption, this will awaken the patient. This will actually facilitate early weaning of the patient from the ventilator. So next is the subglottic suction. So how is this subglottic suction going to help? That we'll see it in detail later. Oral chlorhexidine care daily, DVT prophylaxis, stress ulcer prophylaxis, maintaining the cuff pressure around 20 to 30 centimeters of water, and limiting the circuit changes. So it is not indicated to change the ventilator circuit routinely. So you will have to change the ventilator circuits whenever you find it really soiled. So these are the basic steps of hand hygiene. I feel like everybody would be knowing this. These are the 5 moments of hand hygiene and the 7 steps. Okay, before and after touching the patient, before any aseptic procedure, after any exposure to the body fluid, after touching the patient's surroundings, and the 7 steps of hand washing. So elevation of the head end, it minimizes aspiration, especially gastric, oral and nasal secretions, and it is going to improve ventilation as well. Daily oral care with chlorhexidine. So how much will be the concentration of the chlorhexidine? It's going to be 0.2% chlorhexidine gluconate. Every shift ideally, every 6 to 12 hourly should be the oral hygiene provided to the patient. So it decreases the bacterial load in the oral mucosa. And this evidence has shown that by doing this, we can effectively reduce the rate of ventilator-associated pneumonia. So we were talking about the sedation interruption or sedation vacation. So you have to have a specific protocol of stopping the sedation at a specific time, assessing the conscious level of the patient. If the patient is really responding well and on minimal ventilatory support, relatively off the vasopressors, doing well, you have to do a protocolized spontaneous breathing trial. That is, try to make the patient breathe spontaneously on the ventilator by decreasing the settings, either by shifting over to a spontaneous mode like a pressure support ventilation, and then assessing the patient. So this is going to facilitate early weaning of the patient. So what is a subglottic suction? You can see this endotracheal tube comes with a cuff, okay, or the pilot balloon that inflates the cuff. And there are some specific tubes that come with a subglottic suction. So this is a lumen that is almost molded with the wall of the endotracheal tube, and the opening of this lumen ends just above the cuff. So studies have shown that if this port is continuously being suctioned with the 20 centimeters of water, that is, some ICUs have a specific subglottic suction device which is connected and they do a continuous suctioning. This prevents microaspiration that can happen. If not all ICUs are equipped with such devices, but then if we have a subglottic suction, we can just aspirate with a syringe every second hourly. So how does this prevent? Though this cuff here actually blocks the lumen, prevents aspiration, there can be micro aspirations happening. So when the patient is under sedation, patient will not be able to produce an effective cough, or the patient will not be able to swallow. So there can be secretions that are actually accumulated above the cuff. Slowly these secretions can seep in. By periodically aspirating the secretions that are above the cuff by the lumen through the subglottic port, you can actually prevent this microaspiration happening. So cuff pressure monitoring. So we had also seen that there is a cuff that is occluding the lumen of the trachea. So above the cuff, there can be secretions that are seeping in. So if the cuff pressure is not appropriately maintained, so there can be a gap between the trachea and the cuff. So the secretions can seep into the trachea and go inside the alveoli, and that will be a source of infection. And to prevent this, what you have to do is, this is a cuff pressure manometer. So this can be, the pilot balloon can be connected this, and there is a red colored button over here, wherein you can actually, by using this manometer, you can even inflate the balloon and the cuff, and you can monitor and you can fix the cuff pressure. So stress ulcer prophylaxis, by giving a proton pump inhibitor or a H2 blocker, what we can do is that we can decrease the acidity of the gastric contents and also decrease the secretions, gastric acid secretions. So this will in turn prevent aspiration of gastric contents. The next one is the DVT prophylaxis. Most of our ventilator patients are prone to have clots, deep vein thrombosis. So to prevent this, either you have to provide a chemical prophylaxis or like a heparin or a low molecular weight heparin. Or in case if there is any contraindication to anticoagulation, you need to try on the devices which pneumatically compress the calf muscles and facilitate blood flow from the veins. Okay, these are the various components of VAP bundle that we have looked into. Okay, so we can have a small MCQ session. So we'll get to know how you have understood. So I wish that everybody responds by putting your answers into the chat box. So which of the following is not a component of the standard VAP bundle? Elevation of the head end of the bed, daily sedation vacation and assessment of readiness to extubate, routine changing of ventilator circuits, peptic ulcer disease or prophylaxis. Yes, you can unmute yourself and answer. That is also fine. I can see, yeah, Allah. Yeah, you can answer in the chat box. I'm not able to see the chat box. Dr. Juhi, are you able
They
to?
are answering mostly C, Dr. Priya. 1 or 2 Ds, but mostly C.
Okay, that's great. So routine change of the ventilator circuits are not required. Okay, whenever they are soiled or malfunctioning, only then it's required to change the circuits. The purpose of daily sedation interruption is to prevent DVT, reduce the risk of ventilator contamination, facilitate early extubation, improve patient comfort. So I see C as the option over here, and it is to facilitate early extubation.
Yeah, few have answered C.
Okay. Which of the following is recommended to reduce the VAB incidence in patients expected to be intubated for more than 72 hours? Use of cuffless endotracheal tubes, early tracheostomy, subglottic secretion, drainage, the endotracheal tubes containing a subglottic drainage, or routine antibiotic prophylaxis. So the answer is subglottic drainage. So next we'll be looking at the CLABSI bundle. So what is CLABSI? A central line associated bloodstream infection is defined as a laboratory confirmed bloodstream infection, not related. It should not be related to an infection at any other site. Okay, you should have ruled out other sites of infection, and it develops after the patient had a line for at least 48 hours. Or it can develop, suppose if you have removed the central line in the morning and the patient has developed fever and signs of sepsis within 24 hours, you can consider that also like a CLABSI. So it should have developed after 48 hours of placement of the line, or it can develop within 24 hours of removal. Okay, what are the specific potential routes of infection? So how can this infection happen? It can happen prior to insertion by itself, because if the device is contaminated even prior to insertion, if the skin asepsis is not appropriate, for example, if the skin is not appropriately prepared with a chlorhexidine, 2% chlorhexidine solution, or handling of if the hub is not appropriately handled. So we always say scrub the hub for 15 seconds prior to giving any injection. So scrub it with alcohol. So that is something very important we have to look at. And if the medication or the fluid that we are giving is going to be contaminated, so that can be a potential source. The rare possibilities would be some other infection which has to the blood, and that can actually cause infection to the line. So these are the various potential routes of infection that can happen. How can we prevent that? We have two bundles, okay? One is the insertion bundle, another is the maintenance bundle. So what are the good practices that you will consider while placing the line? So when you are preparing for the line placement, make sure everybody's hand hygiene is appropriate. Next would be appropriate skin preparation. So 2% chlorhexidine is the ideal preferred solution. And the personal protective equipments or the maximal barrier precautions is what we normally say. And you have to select the appropriate site of insertion. For example, which would be the preferred site. So are you going to place a femoral line or a subclavian or a IJV? So which line you're going to prefer? The subclavian would be the preferred site because the chances of infection is less. The femoral, because of the contamination from your perineal contents. So this can become easily affected. So better not to go in for the femoral line unless and until it is really indicated. Otherwise, go in for the subclavian or the internal jugular axis. And always cover it with a transparent dressing whenever possible. So these are the 5 components of insertion bundle: hand hygiene, optimal site selection, maximal barrier precaution is something very, very important. Chlorhexidine more than 0.5, that is 2% is the recommended chlorhexidine dose, and patient positioning and sedation. So what is the maximal barrier precaution? So person and who's assisting, person who is placing, assisting should be wearing a glove, a sterile glove, a sterile gown that is covering the entire body, and the person has to wear a cap as well. So this is maximal precautions for the person who is performing it, and the patient should have a whole body drape. It should not be just covering the side or half of the body. It should be a full body drape. Entire head to toe, the patient should be covered, exposing only the site of entry. So this is very, very important. And optimal catheter size selection, we had already spoken about this. And the maintenance bundle. Whenever you look at a patient who has a central line, always ask one question, okay, whether this line is really required or can I remove this? Okay, so always review and document whether the line is required, the site of entry. Is there any signs of inflammation? So sometimes you can see redness. The patient might be complaining of pain. There can be tenderness around the site. There can be even pus coming out from the point of entry. So those are signs of infection. And that scenario, you need to think of really removing the line. So before accessing the line, you always have to perform a appropriate hand hygiene and scrub the hub for 15 seconds before injecting, and always allow it to dry and then inject. And always, if you're giving TPN or blood, you have to have a dedicated lumen. Okay, so we have spoken about this already. So we'll go into the questions. So which of the following is the most effective strategy to prevent CLABSI? Routine use of antibiotics, daily changing of central line dressings, strict adherence to hand hygiene, asepsis, flushing the catheter every hourly. So I have seen a few options saying C. Yes, the correct option is strict adherence to hand hygiene and asepsis. Okay. Routine use of antibiotics is not required to prevent CLABSI. Okay. So, and daily changing of dressing is also not needed. So, which of the following is a key component of a central line insertion bundle? Routine blood cultures, inserting lines in the femoral vein whenever possible, full barrier precautions during insertion, immediate administration of antibiotics. I don't see any answers. Yeah, I can see a few C's. So full barrier precautions during insertion is very important. So what is the recommended skin antiseptic for central line insertion? I've told multiple times, so I hope nobody goes wrong with this. D. I see 2 Ds coming up. Okay, so it's a 2% chlorhexidine gluconate solution. Okay, so next we look at the 40 bundle, catheter-related urinary tract infection. So whenever the patient has a bladder or kidney infection related to the urinary tract with an indwelling catheter that has been in place for more than 2 calendar days, then you consider it as a CORT. So how can this happen? So it can happen either during placement or after placement. So during placement, it is extraluminal. Extraluminal in the sense that is around the catheter. When the catheter is placed, if the asepsis is not appropriate, then the patient can develop a infection, or it can be an ascending infection from the perineal. If the perineal care is not, the vaginal or the bowel care is not appropriately given to the patient, then the patient can have an ascending perineal bacteria that can contaminate the catheter, or during manipulation. So these are the various methods where the patient can develop a urinary CORT. So intraluminal, whenever there is a break in the catheter. So in this should be, we need to maintain a closed drainage system. So it can happen if there are any leaks in the tube. So this is one of the important reasons. And if there is a kink or loops that is causing stasis of urine in the bladder, that can be other mechanisms by which it can happen. So how can you prevent that? Hand hygiene is the very important step. When you're placing the catheter, maintain asepsis. That is another important step. And always think, is it really required? If the patient is able to avoid self-void, then always remove the catheter whenever it's not required. And if the patient has a catheter, what are the things you have to do? Maintain a closed drainage system. Okay. And how can you maintain a closed drainage system? Never accept any leaks or anything, because that's going to be a portal of entry. Always, if there is a leak or some kind of, if the fittings are not appropriate, always change it. And you'll have to fix the catheter to the inner aspect of the thigh to avoid either pulling or tugging. Whenever you're mobilizing the patient, it should not actually move. So if it's moving, what can happen is that there can be movement of the catheter inside the tip inside the urinary bladder that can injure the mucosa. So that can in fact produce bacteremia. Okay, that can result in a infection. So, and also avoid any kinks or any kind of loops that are getting formed. So these loops or kinks prevent bladder drainage. So that's not going to be a continuous drainage. So that's going to cause stasis. So whenever there is stasis, there is a chance of infection that's going to happen. And whenever the bag is getting filled, always empty it appropriately. Okay, and early removal. So, and also the level of the bag should be always below the level of the bladder. So these are the various systems that are even available to fix the catheter. And if you're going to sample, so don't disconnect. And these are needleless sampling ports that are used for collecting urine samples. So which of the following is the most effective measure in preventing COT in ICU patients? Routine change of urinary catheters every 72 hours. Daily bladder irrigation with antisepsis, avoiding unnecessary urinary catheterization. Use of triple lumen catheters for all ICU patients. So I can see a lot of C's coming in. So let's see what the answer is. So avoiding unnecessary urinary catheterization. So what is the role of catheter securement devices in preventing COT? Reduce biofilm, prevent catheter blockage, reduce urethral trauma and movement, aid in quicker removal of the catheter. So there are a lot of people saying C. So the answer is right. They reduce urethral trauma and movement. Which of the following statements is true about antimicrobial impregnated urinary catheters? They should be used in all ICU patients. They completely eliminate COT risk. They are only recommended when COT rates remain high despite standard bundles. They should be changed every 48 hourly. So the answer is they are only recommended when the COT rates remain high despite standard bundles. So why is it? Usually there are antimicrobial coated central lines available, catheters, urinary catheters that are available, that are going to be very costly, in fact, for the patient. So the other measures, whatever we can do, we can definitely, the other measures, whatever we have spoken about, that you have to employ. But despite that, if the urinary catheter rates are going to be high, then you can consider that. So the next very important bundle that we all have to know is the sepsis bundle. So the sepsis, most of our patients in the multidisciplinary ICU have some kind of infection. They end up in hypotension. And whenever the patient is coming to the ER with hypotension and a picture of sepsis, what are the things that we have to do immediately? And what is a sepsis care bundle? The sepsis bundle is a 1-hour bundle. So what are the things that you have to do to a patient to actually get a good outcome? So these are the 5 things that you have to remember that should be done within 1 hour. So you have to take 2 tests. So one will be measuring the lactate level. Another, take out cultures. Okay. Take 2 sets of blood cultures and then administer. And if there is a clinical suspicion of sepsis, then you go ahead and give the broad spectrum antibiotics. And then if the patient's mean arterial blood pressure is less than 65, you will have to give in fluids to the patient. Okay. There is a recommendation to start as early as possible vasopressors also, then gradually come down on the vasopressors. Hydrate the patient as well, simultaneously think of starting the vasopressors to maintain a mean arterial pressure of more than 65. If your initial lactate is more than 2, after your fluid resuscitation and your vasopressors and starting your vasopressors and maintaining a MAP of 65, you can recheck the lactate level. So that is the sepsis bundle. So what is the primary goal of the sepsis bundle that we are talking about? To reduce hospital admissions, to improve antibiotic resistance, standardize early treatment and reduce mortality, limit fluid resuscitation.
C's are coming up.
Yeah. So standardize early treatment and reduce mortality. So within how many hours should the sepsis bundle be initiated after recognizing sepsis? I know you all will be very aware of this, but still, because just to emphasize the importance of the time, because that's considered as the golden hour in sepsis. So D. Yes, the 1 hour is the golden hour. Okay, there were previous guidelines of sepsis which suggested we had the 4-hour bundle, 6-hour bundle, and all that. But now we have come to the 1-hour bundle. So, which lab test is considered as a marker of tissue perfusion, hypoperfusion, in sepsis? Hemoglobin, creatinine, lactate, platelet count. So, lactate. Okay, lactate is considered as a marker of tissue hypoperfusion. So when you optimize your blood pressure and you resuscitate the patient with adequate fluids, your lactate levels can come down. Okay, now we are going to talk about the surgical site infection bundle, also known as the 7S bundle. So what are the 7S components of this bundle? First is ensure safety of the operating room. Second, always screen the patients who are undergoing a specific procedure for MRSA or MSSA. Okay, the patient should have a whole body chlorhexidine bath, actually a soap or a chlorhexidine night prior to the surgery or in the morning of surgery. And skin preparation, adequate skin preparation with chlorhexidine or alcohol-based antisepsis. And next would be use of irrigation. Any irrigation, if for example there is a laparotomy that is going on, the irrigation should be kind of based with any antiseptic agents. The sutures can be antimicrobial sutures, and the skin closures should be appropriately done. Okay. So these bundles involves pre-hospital, pre-operative, intraoperative, and post-operative period. In the pre-hospital period, we've already seen actually there should be adequate preparation of the patient with the chlorhexidine shower, and also ensure the patient if the patient is having a surgery that is related to the abdomen, make sure the patient passes adequate bowel preparation. So all these things are pre-hospital. Intraoperative, there should be a checklist. Preoperative, there should be a checklist that needs to be maintained, and always ensure euglycemia and euthermia. Okay, normoglycemia and normothermia are two other important components of the surgical site infection related bundle. Okay, when intraoperatively, so asepsis, make sure there is adequate barrier precautions like the drape, the gown, the sterile gloves, and all that. Along with that, intraoperative antibiotic prophylaxis for a surgical infection. So how much should be given? Okay, that is 1 dose, 1 hour prior to the skin infection. Okay, are we going to continue it post-operatively? For clean surgeries, it is not recommended. Okay, for example, if it is a contaminated surgery, if there is a bowel perforation, if there is a peritoneal leak, and already the patient has some abscess, then there should be a specific reason for continuing it. Or for example, if the patient is undergoing some minor surgery, which is going to be a very clean one, no much of bowel handling and all that, we will not be continuing the antibiotic post-operatively. Okay, and always ensure when a patient comes to the ICU from the OT, make sure the patient's temperature is appropriate. Okay, most of the patients go into hypothermia, so prevent hypothermia. Okay, and also make sure the glucose control post surgery is adequate. This is very important, not only for infection, also for wound healing. Okay, so the next bundle we are going to look at is the comprehensive bundle. With when we are talking about this ICU liberation bundle, when we follow all these components together appropriately, it has shown that the patient's outcome from the ventilator is very good. So what are these components? Okay, first is this is known as the ABCDEF bundle. Okay, we know the ABCs of patient care, airway, breathing, circulation, and all that. This is the important bundle to improve patient outcome from the ICU. Okay, A is to assess and prevent and manage pain. So how can you assess pain? Okay, we have the most of our patients in the ICU do not communicate to us. Okay, just because they can't speak, just because they are on the ventilator. But there are other methods that we can assess pain. Okay, we have the visual analog scale, and we have the behavioral pain scale. And how can we prevent? Okay, by giving adequate analgesia to the patients. Okay, F, family engagement and empowerment. Always involve the family in decision making for the patient. Okay, and making the further plan of care. So always involve the family. Exercise and mobility. If you see a patient relatively stable off vasopressors, then you always think of making the patient sit on a chair beside the bed. Okay, take the help of the physiotherapist and think of early mobilization if there is no contraindication. Delirium is a very, very important component. Most of the time, we fail to recognize and to treat. Okay. Delirium is very important because it in fact increases the mortality. Okay. The patient can be really dull. It can be a hypoactive delirium, or patient can be very irritable, has become confused. Okay. The patient may not have had a good night's sleep. How do you assess and prevent? We have the CAM ICU scale. I think you all must be aware of that, wherein you look at various components, okay? And you can assess delirium. How can you prevent? Okay. There are pharmacological and now non-pharmacological methods that you can employ. First, communicating with the patient appropriately. Those are some of the methods. Okay. If they are wearing like visual aids, making sure that they are having that, they are actually analyzing like what is they are fitting into the environment. So those are the things that you have to look for, the non-pharmacological methods. And the pharmacological methods will be like giving some medication for a good night's sleep, like a melatonin or a haloperidol or olanzapine. So those are some medications that can treat delirium. And the choice of analgesia and sedation. If the patient has pain, then you can give some sedation, both spontaneous awakening and the spontaneous breathing trials. So these are also very important. Spontaneous awakening is, we have already spoken about all that. Okay, stopping the sedation, making sure the patient is awake, trying on a spontaneous move. So this is a very important bundle. So I just wanted to share the checklist that is available in our ICU. So here we have the hospital acquired infection checklist, okay, wherein there is a documentation of all the lines that the patient has, including the urinary catheter, the PICC line or the dialysis catheter or the central line, and which site it is. The patient has undergone some surgery. Is there a drainage tube? So these are the devices, and specific to every device, like day of placement, and like is the patient having, if you're talking about COT-T, if the patient has suprapubic or loin tenderness or any other issues related to the catheter. So this is the continuation of the chart, and this is like every day the nurse who is taking care of the patient will be documenting that. The central line ventilator associated events, okay? This is related to the patient monitoring, and this is related to other the bundles which we have spoken about. And then the surgical site infection, okay? These are the various bundles that are documented, and the infection care nurse will be coming and reviewing this and documenting this. Okay, so we have come to the end of this session. And remember, the most important bundle is that it is not going to be a individual act, okay? Prevention isn't an individual act, but it's a collective responsibility, okay? We all should be taking the responsibility collectively and performing it. So that will improve patient outcomes.
Thank you, Dr. Priya. It was really very informative presentation.
I can hear somebody talking, but the voice is not clear.
Hello? Can you hear me, Dr. Priya? Let me do this side.
Yeah, I can hear you vaguely, but it's not clear.
Yeah.
If you can type in the chat box, or you can just adjust your mobile and make a little bit more clear.
Better now, Dr. Priya?
Yeah.
I was just saying that it was a very beautiful talk, Dr. Priya, and it was really informative. And you just presented everything in a very concise and a very easy way. And I'm sure that all the nursing colleagues must have learned a lot, because I learned. And just wanted to summarize a bit, which I just noted. So for my nursing colleagues, just want to say why these are called bundles. Because these are just evidence-based set of practices, and in various studies they've found that if you practice them in an isolated manner, just like out of 5 steps, if you follow 1 or 2 steps, they haven't made much of a difference. But if you have practiced like in a VAP bundle care or a Quati bundle care, if you follow all these 5-6 easy steps, they have found that the infection rate have gone pretty down. So that's why they are called as bundles. And they had an all or none phenomena where like practicing all of these sets together has made a difference rather than following 1 or 2. So that is one thing. Other thing I was just, so just to summarize again, these ICU bundles form a very important pillar of any infection control practices being followed in a hospital. And I'm sure every hospital has their own infection control team, which comprises of an infection control nurse, a head, other intensivist, a pharmacist, and everything. So their responsibility is more to just, daily or in a frequent interval, just to monitor that these parameters or these practices are being, practiced in the ICU setups. And collectively, as Dr. Priya mentioned, that it's a team game. It's not a single individual can make a difference. So for the nursing colleagues, since you are in a direct contact with the patient and these bundles are primarily, in direct contact with you, so I would just ask that, taking not as a just that it's a sake of a work, just do it for the sake of the patient, because your practices and your this thing will just help in patients recovery and safety, I would say. And it has been found that if we follow these bundles and in a very effective manner, they bring down the patient's morbidity and mortality, as hospital acquired infections are the major adverse event and adverse effects which have been seen once the patient is in a hospital setup. So what is in our hand is the best we can give to the patient, and practicing such simple steps would be easier for us, but it will make a very large difference if we do it in a very nice manner for the patient. So I would just request everybody to follow these ICU bundles in the best possible way you can. And just note on the hand hygiene, I would just suggest it's a very simple thing, very common thing, everybody knows, but somehow still the rates in our hospital surveys and everything, the hand hygiene practices have not met to the criteria it should. So I would just say that hand hygiene is the simplest thing we should do, but it has been found that it has made the major difference to a patient's infection safety. That's all, Dr. Priya. Anything you want to add?
There is one question actually. For irrigation, patient urine bag should be empty after how much ml? So I think Alina has been asking like how much, like after how much the bag is filled, we need to empty.
Yes, ma'am.
Okay, there are two types of urinary bags that you have. Normally, the one which we have in the ICU is a urometer, which has a like 150 or a 200 ml, which is emptied into another like bag. Okay, there's a urometer, and then associated bag. If I can show you in this picture. So there is a, if you can see here, there's a urometer. Okay, this has a 200 ml almost. It's not beyond that. So whenever it's almost like 300 ml. So when this, it depends on the various manufacturers. But this is when this is getting filled, you empty into another bag, which is like beside. When you are monitoring with a full, only the this bag is available, then you can't be kind of monitoring the urine every hour. So in that scenario, you'll have to like almost when the bag is almost getting half or a little beyond that, you'll have to empty it. When we are talking about this urometer in the ICU, you shouldn't be allowing it to overflow. So whenever it's getting almost getting filled, then you'll have to empty it. Hope that is okay. Or you wanted to ask something else?
She's asking that without the
Without
urometer.
the urometer. Okay, you don't allow it to overfill. That is what, like if it's almost like beyond half the way full, we normally empty it. There's nothing like a proper recommendation for that.
Yes. Lena, just the concept is that you don't need to overflow, maybe, just that you need to empty it on the basis where if you don't have a urometer.
Anybody else has any other questions?
Any other questions? Any other questions? So she's saying, Dr. Priya, that okay, so
Yeah,
she
that's what we don't have any specific recommendations for that. But normally, when you allow it to fill it up to like 2 liters or like 1 point beyond that, normally there will be a weight that is going to stretch the, the catheter and like if it's like way beyond 1,000 ml, you better get it like drained, empty it. Thank you. Anybody else has any doubts or can we wind?
I think we can wait for like few minutes, Dr. Priya, if somebody else wants to write something. And one thing for my nursing colleagues, once you transport a patient or shift a patient, just make sure that during shifting also your Euro bag should be below the bladder level, should not be on the bed, because then that will also increase these infections. The idea is to keep it hanging, below the bladder and not touching the floor. Yeah. Anything else anybody wants to ask?
Ma'am, please conclude the session.
Sorry. If no more questions, then should we close the session?